Good morning, everybody. It's indeed a pleasure to be here in Vienna at the European Gastroenterology Week talking about low-resource settings. I think cost optimization, low resource, is now a global phenomenon. And it's indeed an honor that UEGW thought of presenting something on the low-resource settings, the developing world, and what we are going through. Warm greetings from Hyderabad, India. Terminal ileitis in tuberculosis endemic populations. I'll just describe how things work in our part of the world. Traditionally, IBD was a disease of the West, an art of the Western world. Far away from the West, in our developing world, we were happy. IBD was rare. Crohn's disease was suspected rarely on barium studies or at surgery, even up to the 70s. Ulcerative colitis, a few cases of non-specific colitis were reported on and off, and that too, they thought it was non-amoebic colitis. So common was infectious diseases. This was the land of infectious diseases, the land of diarrheas, malarias, filarias, and that's what we thought, a region endemic to tuberculosis. If you see here, the whole green part is actually the part where the most population of the world stays, is the part where tuberculosis is endemic. The numbers remained low up to the 80s when there was science, technology, and revolution, industrial revolution. We got into the headlines for all the good things that we did. But together with it came urbanization, pollution. We had the signature McDonald's collection, our diet changed, and we came into the headline for the other things, the bad air days and how Asia got fat. Together with this, IBD came to the non-Western world. Today, Southeast Asia is an emerging infectious diseases hotspot, and at the same time, IBD is on the rise. So IBD and infectious colitis is together a common encounter. Two lions playing in the same field. The diagnostic dilemmas of terminal ileitis. If you see these pictures, ulcers in the terminal ileum, of course we think of Crohn's disease. Commonest site of involvement is terminal ileum in 80% of cases. Isolated terminal ileum involvement is noted in 30% of Crohn's. Smaller ulcers now may progress to larger ulcers. We need an early treatment to avert major complications. But the question remains, are all these small ulcers actually Crohn's disease? For the developing world, no, we have a large range of infectious diseases which can also cause similar ulcers. There are drugs which can cause, there are over-the-counter medications available which can cause such ulcers. So the situation is far more difficult, and sometimes we learn the hard way. We thought this was an ulcerative colitis with backwash ileitis, with a flare, as and where, how you want to put it. The biopsy showed it was teeming with amoeba. So, for every case, we are extra cautious. We need to take family, medical history, signs, symptoms, stool cultures, and every other investigation to probably rule out any of the infectious diseases. But the trouble primarily comes with tuberculosis and Crohn's disease. Just to give you an idea of the extent of the problem, TB is one of the most common infections in India, and 30% of the global burden is in India alone. 90% of infected patients develop latent rather than active disease. A third of the world's population is thought to have latent TB. And we are talking of increasing Crohn's. Anti-TNFs play a key role in the host defense against TB, and anti-TNFs may increase the risk of developing TB fivefold. So as I said, there are two lions in the same field. Of course, TB is one of them. So TB and Crohn's disease and terminal ileum and terminal ileitis, you can see how our reports look. Colonic Cox. Cox, however, means tuberculosis. TB is considered sometimes a social stigma, so we use the term Cox, or a Crohn's disease. The diagnostic challenge, they're just like two identical twins. When we check, they're clinically similar, they're radiologically similar, endoscopically similar, and even the histopathologist can only sometimes say that there are granulomas, could be TB, could be Crohn's. In fact, 4 top situations where you should take a second medical opinion was discussed in the CNN a few years back. And I got this shot from there. They said medical termination of pregnancy for suspected fetal abnormalities. And with all those things, the third was decision dilemmas before treatment of tuberculosis versus Crohn's disease. The problem is actually real. You know, just to tell you a small story of a young girl, she came to our hospital in 15-year-old high school, abdominal pain on and off. Symptoms had aggravated with pain, recurrent vomiting, more than 15 kgs of weight loss, and she was having watery loose motions. She had low-grade fever occasionally, which was undocumented. Colonoscopy showed white-based ulcers in the ileum. The biopsy was non-specific. We did a CT enteroclysis. It showed multiple segmental wall thickening with enhancement in the jejunum, ileum, perienteric vascularity, focal areas of thickening in the ileal loops with a normal IC junction, multiple small mesenteric lymph nodes. In view of the long history of more than 4-5 years, imaging and colonoscopy typical of Crohn's disease, budesonide was started while we awaited further screening results. Course of steroids was given, subsequently did not work. Treatment was planned in the lines of Crohn's disease. Chest X-ray was normal, TB quantiferon negative, MAN2 negative, no family history of tuberculosis. The TB PCR from a second colonoscopy, which the surgeon actually wanted, showed a positivity. In view of that, we started a 4-drug ATT. And within 9 months, there was a 9-kilo weight gain. A repeat colonoscopy showed mucosal healing, and CT enteroclysis showed a mild thickening. The lesson we learned, and for this part of the world, it's worthwhile to err on the side of tuberculosis. How to differentiate? A very simple thing. Do whatever you have. Sometimes, if you are in a dilemma, even use empirical antitubercular therapy. Mix and match on a case-to-case basis. Empirical therapy, however, has its limitations. It may delay the treatment for Crohn's. It's difficult to refute a diagnosis of TB at a later stage. Severe adverse drug reactions can happen to TB if we are giving a Crohn's patient. And treatment for Crohn's disease is disastrous if we miss an intestinal TB. So we studied this actually, risk factors for diagnostic delay in Crohn's disease and their impact on long-term complications. We found that increased incidence of stenosis and need for surgery with a delayed diagnosis. Only 45% of cases could have a confident diagnosis by 12 months. At least 30% patients received TB treatment initially, did not respond, and turned out to be Crohn's. And an average of 2 to 3 physicians visited before the diagnosis was confirmed. So anti-TB therapy prevented early diagnosis, but interestingly, 50% of patients who received antitubercular therapy actually responded clinical response, and sometimes even endoscopic response. So despite initial clinical response to antitubercular therapy, however, long-term stenotic complications were higher. So how do we treat, therefore, in this kind of a scenario? And we have written this recently in a paper we published in Lancet. When there is a dilemma between TB and Crohn's disease, meaning there's no caseating granulomas or culture positivity, and TB not identified at an extraintestinal site, we get all the tests done. And then if we find that there is a previous history of TB, TB contact, anything to suggest surgery, suggest tuberculosis, we treat as tuberculosis. If not, we start treatment in the lines of Crohn's disease. And as I mentioned, if there is a diagnostic dilemma, we treat as TB. So worthwhile to err on the side of TB. If the TB culture comes positive and there's clinical improvement, we complete therapy. If negative, no improvement, we re-evaluate. And if culture negative, but patient doing well, of course, we would complete the anti-TB therapy. Even if we start Crohn's treatment, it's absolutely essential that we complete the TB treatment if the patient is tolerating the drug well, because the dilemma persists later on as well if the TB treatment full course of at least 6 months is not completed. Having spoken of all this on TB, infectious diseases, and the developing world, it is important to recognize that there is an epidemiologic transition in progress. Communicable diseases are coming down in our part of the world. We conducted the AIG IBD Rural Healthcare Program. It's an ongoing program, a door-to-door survey for IBD and GI diseases. And you can see our young doctors and research associates going in the village, house-to-house survey looking for gastrointestinal diseases. This is around the city of Hyderabad, the districts around there. Symptomatic patients are evaluated at the local camp daily. We do the local automated blood tests, the mobile ultrasound, and dispense drugs to those who need for any GI diseases. A doorstep endoscopy in the mobile van is done every week on Fridays. What we found after 15,000 colonoscopies was there is a rising trend of IBD in rural India. There is obesity, there is reflux disease, and to our surprise, the number of infectious diarrheas, tuberculosis, amoebiasis have actually come down. This was a surprise to us also, those who are living in the cities, and terminal ileitis was common. So terminal ileitis in itself, is it a separate entity? The story started long back in 1936. Epitome of current medical literature first mentioned that is acute terminal ileitis a separate condition or an early Crohn's disease or an acute form of a classical Crohn's disease. A new marker, so in our lab, we have a young PhD group who are working in the microbiome lab, a new marker to distinguish Crohn's disease and terminal ileitis. So out of 26 patients with confirmed Crohn's and others with isolated terminal ileal ulcers and healthy, those whom we have ruled out any infectious diseases, the gut microbiome was checked. Interestingly, what we found was both the bifidobacterium and ruminococcus were significantly reduced in both Crohn's as well as terminal ileitis compared to the healthy, but the Faecalibacterium prosonidzeae in Crohn's disease was significantly lower compared to terminal ileitis alone. So there is a difference. It appears to be in the microbial signature between Crohn's disease and a few ulcers in the terminal ileum. It means a lot to us. It just means that maybe we need not initiate Crohn's disease treatment in a few patients with a few terminal ileal ulcers, and just keep it on follow-up. We analyzed using the bioinformatics software for the predictive metabolic pathways, and to put it in short, what we found was the bacterial stress response. The PP expression in Crohn's disease was significantly higher in Crohn's disease compared to terminal ileitis. So the gut microbiome may provide a difference, and we may be able to differentiate who to treat and who not to treat. So in summary, terminal ileitis in the TB endemic regions is an evolving area. IBD is on the rise in the developing world where infectious disease is predominant. Infectious colitis and IBD likely to be a common encounter. Terminal ileitis is common in Crohn's disease, but there are numerous bacterial, viral, protozoal infections that can mimic the same. The problem is compounded in TB endemic regions because it's difficult to differentiate. Treatment algorithms require close monitoring for response, empirical antitubercular therapy worthwhile when results are inconclusive. Not all terminal ileitis is specific for Crohn's or TB or infections. Non-specific cases occur. The gut microbiome may be the key differentiator of the future. To learn more of all our troubles, we have this series in the Lancet, challenges in the diagnosis and management of IBD in resource-limited settings in Asia. This is our center and the team across the COVID period, all masked. And we cordially invite you to the AIG IBD Summit 2023, April 7th to 9th. Thank you so much.
Thank you very much, Ruba. This was a very interesting presentation, and we have learned a lot, really. So we'll start by questions from the audience, if anybody wants to have a question for Ruba. Okay, so we'll go to the online questions. The first question for you is, okay, please.
May I ask you? Oh, thank you.
Yeah.
I'm Geert from Amsterdam. Rupa, that was really outstanding. Thank you for communicating all this. In the West, we often have patients that screen positive for tuberculosis, not in the gut, but presumably in the lungs or somewhere else that we don't know. And then we start anti-tuberculous treatment. And those patients have IBD, so they also need IBD treatment. How do you handle in India the relationship between the start of the anti-tuberculosis treatment and the start of then, for instance, anti-TNF?
I think this is a very good question, Gert. What we do is we start treatment, and then we start treatment first with TB treatment. So if, say, TB quantiferon is positive, but there is no other evidence. And then we decide on the timing of anti-TNF based on how sick the patient is. So ideally, I would like to defer up to 2 months. But if not, we can go even as early as 15 days to 1 month of starting the anti-tubercular therapy.
Okay.
The interesting part is what we are more and more finding that anti-tubercular therapy does, maybe the antibiotics in it, does have some role in Crohn's disease as well. So there is some clinical improvement. So we are in a frank discussion with the patient whenever there is a non-specific diagnosis, the algorithms are explained, and switch from one to the other happens. But we don't stop the anti-TB drug, and I think that's the message, that the 6 months of anti-TB drug, we try to complete it as much as possible.
That's very helpful, thank you.
So next question, please.
Hi, great study. Purnima Bhatt from Canberra. I wanted to ask you, the quantiferon gold assay works on the T cells being specifically reactive to the tuberculin antigen. And I wanted to know whether anyone had looked at it, whether you're aware of studies where the T cells in the local biopsy specimens from the terminal ileum were also reactive.
I'm not aware of any such study, but we actually analyzed the CD70 marker of mesenchymal cells in the biopsies, and we found that that was a clear differentiator between Crohn's disease and TB. The problem is these mesenchymal cells are present around the granulomas. So the diagnostic dilemma persists if there are no granulomas. But if there are granulomas, we are checking the CD70 marker, which is more specific for Crohn's disease than for tuberculosis.
It would make an excellent point of care test if you can turn it into that.
Yes, so we are doing it when there are granulomas. There are some other studies of PFOX53 and other, but none have really reached the standard where we can say that it can be used. But CD73, we are using it for our routine practice.
Thank you.
Okay, so we have two online questions, quick online questions. The first is, what's your algorithm to rule out tuberculosis in ileal ulcers? And what are the endoscopic features or immunohistochemical characteristics to differentiate between tuberculosis versus Crohn's?
Yeah, I think the first thing that I'd like to say is that whenever I'm talking of a difficult case, it is a case where we have exhausted all the options. So yes, TB and Crohn's, there are the classical, if you see longitudinal ulcers, if there is perianal disease, you're thinking of Crohn's more likely if there's a family history. If there is a family history of tuberculosis, there is a recent contact, if there is fever, if there is a lung infection, we are talking more of TB. But there will still be that 20 to 30% of cases where TB quantiferon is negative. We've given biologics, and then a few develop tuberculosis. So it is, there is no one-word answer. Of course, if you find a TB culture positive, that is a definite TB, and we are actually relieved if we see that. So we try all tests that are available, including the TB PCR DNA, the TB PCR RNA for every biopsy sample. If there is a granuloma, we check for the other markers, CD73. So all tests have to be done. The point of this talk is that this spectrum has overlaps, and you always, as clinicians, have to be aware that there is response or no response, and that continues until there is complete healing of the ulcers. In fact, even after we complete TB treatment for 6 months, sometimes 9 months, we call the patient back within a year for a recheck colonoscopy to see whether there was additional Crohn's, a theoretical but a definite possibility that could happen.
Thank you very much, Dr. Banerjee. I'm just following up on the same question, and I would ask, we are in a session talking about low resources, so what would be the algorithm in your opinion? There are also guidelines about this, in very low resources settings to rule out tuberculosis? And
yes, so low resource settings, again, I don't want to label only the developing world for low resource settings. I think cost optimization is important across the globe. We are dealing with a population which is genetically different from the Western world, and I think some drugs do work. What we do is we start and we do the step-up type of treatment for Crohn's disease. We definitely use azathioprine. For the very poor, we use sulfasalazine, and that is much cheaper than even the regular mesalazines. Azathioprine, and then biologics when it is needed. We have a definite exit strategy for biologics, and we discuss with the patients, and we have found that we can, in at least 50% of patients, to stop biologics with the intention that if there is a relapse, we restart. So in the view of TB and in the view of high cost, a combination algorithm, we definitely do not continue maintenance biologics for ages. Most of our patients do not have insurance. Having said that, I also feel that we need more cost-optimized treatment algorithms for Crohn's disease. For TB, most of the treatment is funded by the government, and I think in the low resource, most countries that I'm aware of, as part of the IBD Emerging Nations Consortium, around 25 countries, most countries, tuberculosis treatment is kind of funded by the government, and low resource does not hit back so much.
Okay, thank you, Ruba. Last question for you, please, from the online audience. Will fecal microbiota treatment help if there is dysbiosis in the terminal ileum?
I think this is a good question. Our purpose was just to see that, the microbial signature of TB and this terminal ileitis and Crohn's disease per se was different. How we can treat that, how we can increase Faecalibacterium prausnitzii or a single live biotherapeutic strain, will it come or not, is a further long-term answer. I don't think we are still in a position to say. We can say that diagnostically, if you find this kind of a microbiome, maybe you should not rush into a high-dose Crohn's disease treatment for isolated terminal ileitis or isolated terminal ileal ulcers.
I have a final question maybe for your presentation is, what's the role of surgery actually when we have this dilemma? There is some patients where surgery maybe is a better fit
This
to
is a very
discriminate.
good question. And so if I find stricturing ileocecal, limited ileocecal disease, and there is a dilemma between the TB and the Crohn's, we work very closely side by side with our surgical colleagues, and limited ileocecal resection has actually given us a very good response. We will not start biologics for limited ileocecal disease where there is a stricturing. Because what we do is we do surgery, and post-surgery keep a regular follow-up, and then try the azathioprins, thiopurins, and methotrexates of the world, which are low cost, and save the biologics for a really rainy day at the end of it.
And just to follow up, on pathology, on specimen, surgical specimen pathology, how do you rule out completely tuberculosis?
I think surgical specimen pathology is often much better than the mucosal biopsy we send the pathologist. So they get the whole full thickness biopsy, and differentiation between TB and Crohn's becomes relatively easier. But nonetheless, for every patient, even if we get a biopsy of tuberculosis, we do the recheck colonoscopy within a year so that there's no recurrence.